Hi, in this lecture, we are going to wrap up our study of the cardiovascular system and Unit 1 by talking about some of the clinical application pieces for blood vessels. So we've touched on our atherosclerosis and arteriosclerosis a little bit as we've been going through the material, and they're very similar in that they're going to decrease the lumen of the blood vessel. So what happens with atherosclerosis is you start to get deposit of plaque inside, and notice that it narrows the lumen, which we know is going to increase resistance. Remember, we said that it would increase what was called TPR, and that was a factor of afterload. And so as it increases this resistance, your heart, your left ventricle has to contract harder and harder and generate more pressure to overcome that resistance. Now, what can happen is once you get this deposit of the fats, it can harden into what's called plaque, and calcium gets deposited. So arteriosclerosis is sometimes called hardening of the arteries because the calcium makes them very, very stiff. So they're narrowed and they don't move. They've lost that elasticity and it affects blood flow. Now, what I want you to know is just general steps for atherosclerosis. So when I put my head here, I'm never quite sure where to put my head. So I'll move it around a little bit. So all I want you to know, we're not memorizing every single step, but the three basic things that we know has to happen to develop atherosclerosis is some sort of injury. So something injures that tunica intima, right? That inner lining. It could be having too many lipids in our blood, high blood pressure, the blood hitting it, smoking, the chemicals in the smoke, toxins, viruses. So there's all kinds of factors. And so step one is there's some kind of damage. And then what happens is we do this step two, we start to get the inflammatory response. So we get inflammation, right? We have macrophages come to the area. They try to eat up any dead debris, bacteria, clean the area up. A lot of monocytes, remember, they become macrophages. They come in the area. And so one thing that happens when we get all this inflammation is that we know that these macrophages show up and start to eat, and then they can rupture. And what happens is as they start to show up and eat some of the debris, they even start to eat some of the lipid. And then a lot of these cells are going to rupture. And so they call these foam cells. So the macrophages engulf the lipid, and then they start to rupture. There's so much lipid in there. And so it supposedly makes it look kind of like foamy-like, and that's why they call that a foam cell that occurs. Extra cholesterol now comes in and starts to get stuck. And eventually we have this, blockage in our vessel. So we know that if we can avoid the damage to begin with, that's good, that's important. We're going to get some damage no matter what. So if we can decrease inflammation, that's important as well. That's probably one reason why vitamin E is so helpful, right? We have the vitamin E, and we talk about the omega-3s and tuna fish, and they're very anti-inflammatory as well. And then once we start to get any kind of calcium deposit, then we have what's called arteriosclerosis. And again, the issue is you're now restricting blood flow, you're increasing resistance and putting more strain on your heart. Now, a deep vein thrombosis, DVT, you can see right here, remember a thrombus is a stationary blood clot. So these are things that usually form in your lower extremities, typically your calf or your thigh. They're more common in surgical patients. Remember that anytime we have stagnant flowing blood, remember if it's not moving real well, you have an increased risk of clots happening. So if you have a long surgical procedure, then your blood isn't flowing as well. Now they put the compression things on, right, to squeeze the legs and try to keep moving that. But, it is more stagnant than usual. Or if you're on a very long airplane flight, some of those flights are, 8-10 hour flight, then again, you're just sitting there. And we know that that's going to increase your risk of forming a clot. So what happens is when this happens, you're going to have signs and symptoms. It's going to be red and it's going to hurt to touch it. So it actually gets swollen. It's red. And the issue is that, we have our normal blood flow, right? If that clot is forming, if a piece of that breaks off, now we have a traveling blood clot, which is an embolism. And that's a big concern because this is in a vein. And remember that the veins are sending blood back to the inferior vena cava, which is going back to the right side of the heart. And we know that the right side of the heart is a very low pressure circuit. In fact, the pressure in a pulmonary artery, remember, might be 10 or 15 millimeters of mercury versus 120 millimeters in the aorta. So the concern is that it breaks free and we could have a pulmonary embolism, and you block a pulmonary vessel, then you're not getting oxygen, and that can be fatal because it would cause such severe hypoxia. So, the treatment is basically to try to break up the clot. So they'll put you on blood thinners, maybe heparin, to try to dissolve this blood clot. If necessary, they could go in and remove it as well. An aneurysm, on the other hand, is more like a weak spot in a blood vessel, in an artery. And so I like to think of it kind of like the bulging spot on a tire. And so what happens is that a lot of times you'll have like a cerebral aneurysm, or you might hear about an aortic aneurysm. So they're usually named for where they occur. And so what can happen is it starts to swell. So it's like a weak bulging that occurs. And arteries have the highest pressure. And so you wouldn't really know you had one until, unfortunately, it's usually too late. So if that aneurysm should rupture and pop, now you're going to have a bleeding stroke. If it's in your aorta, you're not getting blood anywhere in your body. And I'm not trying to freak you out with some of these stats. You don't have to memorize them, but there is a genetic link. So if a parent had aneurysms, you probably want to be closer eye. Maybe you have regular scans of your brain to check. And so we know it's fairly low risk, but unfortunately, when it ruptures, you have to get to the hospital quickly or it'll be fatal when that happens. Now, hypertension, we know, is blood pressure is too high. We know our normal blood pressure. We say 120 over 80 or maybe 110 over 70. And there's different classifications of hypertension. So I'm not going into like the pre-hypertension and all that. We're just going to memorize and keep it simple that if your blood pressure is 140 over 90, that you have hypertension. And this wouldn't just be one reading, okay? This would be several readings. You do it over a period of time, same time of day. We know there's this white coat syndrome where people go into the doctors and they're so nervous, their blood pressure goes up. We know that like exercise and your sympathetic nervous system can really spike your systolic blood pressure. They don't really affect the diastolic as much. That one doesn't change very much, but the systolic can definitely change. So I had a brief edit, which is why you don't see my face right now. But if we look at hypertension causes, there's two types of hypertension. There's primary, which is known as essential, and there's secondary. Now, most cases of hypertension are the primary or essential type. It's been estimated that about 90% of hypertensive individuals have primary. Secondary is when it's due to a specific cause. So maybe you're pregnant and your blood pressure is up, or you have an endocrine disorder, but there's a specific cause of it. And then once you treat the condition, the hypertension goes away. Primary or essential, though, you can see these risk factors, which I'm sure you're aware of most of these. So when we're looking at primary, one issue is aging. Typically, as we get older, our blood vessels are less elastic, and so you can have higher blood pressure. Lifestyle, huge, right? What we eat, what we drink, smoking, not exercising, all of these are things that can raise our blood pressure. There is a link with your race or ethnicity. It does tend to run higher in African Americans as well as Hispanic adults. And then as far as biological sex, when we're looking at, XX and XY, there is some difference regarding having the 1X chromosome or the 2X chromosomes, where earlier onset hypertension is more common in males, XY chromosomes, whereas females with XX tend to have it later. And then we also know it runs in families. So if your mother or father has hypertension, there's a higher chance that you also will develop hypertension. With hypertension is that you don't really know you have it. Unfortunately, it's called the silent killer because usually the first sign that you have hypertension is you have a heart attack or a stroke. Well, I guess I'll just leave my head over here. So we know that high pressure, right? That's the pressure pushing blood through. We know it damages our blood vessels. It can cause a heart attack. or heart failure, can cause cardiac arrest. It can affect your kidneys. That high pressure wears down your kidneys, and we know it can cause a stroke. Now, if your blood pressure is high, you might notice headaches and nosebleeds, but you don't always get those signs with high blood pressure, which is why it's important to make sure that you check it regularly. So if you have hypertension, what do you do about it? Well, the meds are back. So most of these meds are meds that we use when we treat, we've already looked at this, for heart disease. Sorry, just trying to move my head somewhere. So we have beta blockers, alpha blockers, calcium channel blockers, ACE inhibitors, angiotensin II blockers, and diuretics. So these are the main categories out there. And so remember that since my blood pressure is directly proportional to my cardiac output, if my blood pressure is too high, if I can lower my heart rate, then that would lower my cardiac output and lower my blood pressure. So a beta blocker, right, is going to block the beta-1 receptor. So norepi and epi, neither one can bind. So it keeps your heart rate nice and low. We also know that if we can lower stroke volume, that also might help. So like a calcium channel blocker in your heart would decrease contractility. So again, it would kind of relax the stroke volume. So some of the meds are really targeting cardiac output, and they're trying to lower cardiac output to affect blood pressure. Some of the meds also try to affect cardiac output by lowering blood volume. So remember that blood volume affects cardiac output. And so diuretics are going to increase your urine output. So you urinate more water, it leaves your body and less is in your blood. Now, a whole other class of drugs are going to try to target the blood vessel. So the other way you want to treat hypertension is you want to decrease resistance. We want to decrease that total peripheral resistance. And remember, that resistance was if we were constricting. So if we can open up blood vessels, if we can dilate, that's going to be a really effective way of lowering resistance. And so we have drugs like alpha-1 blockers. These drugs are going to block the alpha-1 receptor from norepinephrine so that the blood vessel can't constrict. We're going to look at ACE inhibitors. They inhibit the enzyme ACE. We already looked at ACE is the enzyme that converts angiotensin 1 to angiotensin 2. Then they even have angiotensin 2 blockers. So now let's say you get to angiotensin 2, so they're ARBs, angiotensin blockers, okay? So when we're looking at these angiotensin 2 receptor blockers, they're not going to let that angiotensin 2 bind and carry out its effects. And I don't really understand why, but I do know that a lot of your patients will be on multiple meds for hypertension. So they might originally try to do something with the blood vessel. They might do something with the heart, if the heart's involved, to maybe let the heart rest. So I put this table in your notes to try to fill it out. And I really want you to understand how the mechanism works for these. I will try to write neatly. So beta blockers. And actually, I would really encourage you to hit pause and see how much of this you can fill out yourself, because a lot of this you've already done. So it's always good to see what you know and what you don't know. So beta blockers. We know that they block the beta-1 receptor from norepinephrine. Now, when epinephrine is released in your blood, it also binds to it. In fact, epi seems to affect your heart more. So if you block the beta-1 receptor, it prevents the heart rate from rising. So it keeps your heart rate low. And then we said that would decrease your cardiac output and decrease your blood pressure. Well, the concern, right, is that it interferes with that baroreceptor response we talked about. So that response, that reflex, doesn't work as well. So I had mentioned, like, if you're lying down and you stand up, right? Your patient's lying in bed, they get up quick. Or you go to a hot tub and you vasodilate and you get out of a hot tub. So anytime your blood pressure decreases, right? If blood pressure falls, the baroreceptor is trying to raise your heart rate to maintain cardiac output and blood pressure. It's not going to work. So you got to be real careful when your patient's changing body positions, etc. Alpha blockers block the alpha-1 receptor. right? Block it from norepinephrine. Well, remember when norepinephrine binds to an alpha-1, it opens calcium channels and lets calcium in. So now you're basically not letting calcium into the arteriole. Well, calcium's necessary to constrict, so this is going to vasodilate. It's going to help lower your total peripheral resistance, right? So it's going to try to lower that to try to help lower the blood pressure. I don't know of a whole lot of concerns with that one, okay? Calcium channel blockers. Now, these are drugs that block the calcium channel. So these are going to affect your heart. One, right? They're going to decrease contractility. We learned about this previously. We called it a negative inotropic effect. So it's going to the heart won't contract as hard. So the idea is it might relax a little more and take the pressure off your heart. But they mainly use because they block that calcium channel. So again, if calcium can't bind to that alpha-1 receptor, we're going to vasodilate our blood vessels and we're going to decrease TPR. So because they affect the heart and the blood vessels, you might not necessarily want to decrease contractility, but they're really good to open up the blood vessels. So the ACE inhibitor, remember we have the angiotensin to the angiotensin 2. This happened in the lungs, and that ACE, angiotensin converting enzyme, was the enzyme. So what an ACE inhibitor does is it doesn't allow that enzyme to work. So now you're not going to get your angiotensin 2. Well, if you don't get angiotensin 2, now you don't release aldosterone and you don't vasoconstrict. So it's going to have a two-prong effect, right, on blood pressure. Well, the other concern, though, is maybe sometimes you need your blood pressure to go up, right? Probably not too much if you're hypertensive, but it's going to block this whole process of angiotensin 2. So another mechanism they have is let's form angiotensin 2 because, it does vasoconstrict, but it does release ADH and aldosterone. So now we're just going to block the angiotensin 2 receptor. And you can see here, we're going to block it at the arteriole. So it's going to basically prevent the blood vessels from constricting. So it's going to be another mechanism to help vasodilate and lower your resistance. And every med has side effects, so I'm not as well versed in the concerns with these. But when we look at a diuretic, remember that's going to make you pee more. So you're going to increase your urine output, which means that your blood volume decreases. And if your blood volume decreases, so does your cardiac output. Well, a concern for this is that we could end up being dehydrated and we could end up increasing the viscosity of our blood, which is going to increase resistance. For whatever reason, they like to put patients on diuretics, first line of defense, but you got to be careful because your patient can become more dehydrated. And anytime you urinate, you lose potassium. It's just every time you urinate, potassium is in your urine. And so if you're urinating more frequently, you're going to be a bit concerned about losing the potassium and having hypokalemia. Now, hypotension is more desirable, right? In fact, that's better. And so when we look at our hypotension, if it's too low, it's going to cause problems. But if your blood pressure is like 100/60, as long as you're not getting lightheaded and passing out, it's better to have lower blood pressure. But now we're look at our systolic. So if our systolic falls too low, so 90, you're still probably fine. We're getting down to 60, 50, it's way too low. Remember that the blood pressure is pushing the materials through the vessels. Now what's happening is we're not having the force. We can decrease blood flow to our organs. Organs become hypoxic and we can go into organ failure. In fact, we're going to wrap up with that in just a minute when we look at circulatory shock, which is happening when your blood pressure is very dangerously low. Things that could cause it if you have low, your cardiac output's too low. It might be low because you're hemorrhaging, because your blood volume's low. Maybe your venous return, you're not getting the blood back to your heart. Maybe you have a very low stroke volume. So these are factors that could cause hypotension. And in your notes, you have orthostatic hypotension. And pretty much everyone may experience this at one time or another. This is when you stand up. So if you go from lying down or sitting and you stand up suddenly, remember gravity is going to drop your venous return momentarily, and there's a brief delay until you can kick in your baroreceptors and raise your heart rate. And in some people, they have a delayed reflex and it doesn't kick in very well. So when they stand up, they might be dizzy or lightheaded for a minute and be like, whoa, and they have to wait or change position slowly. So this is temporary hypotension from a change in body position. Now, I have vasovagal syncope here. We actually already did it in the heart. It was one of those things that I already had, so I just left it. But remember, this is different things can trigger an episode. Syncope is lightheaded or passing out. And so whenever there's, for whatever reason, a big stimulus of your vagus nerve, right, an increase in vagal tone, it drops your heart rate really fast. And so that will cause hypotension, low blood pressure, and it can make you pass out. And there's all sorts of different factors that can cause that. So I want to come back to this idea of shock, and we're looking at hemorrhagic right now. I'm going to move I don't know where to put my head. So this is a nasty wound. So let's say there's some sort of bleed. We're not going to memorize the whole table. I just want you to think about, let's say you have severe blood loss. So you're hemorrhaging. When you hemorrhage, now your blood volume falls. When your blood volume falls, your blood pressure falls. So your body's goal is to restore blood pressure and blood flow, right, to your periphery, to your organs. So the very first thing that's going to happen when this occurs is your nervous system and your baroreceptors. So my chemoreceptors and my baroreceptors jump in. Notice I stimulate my cardioacceleratory and my vasomotor center. I'm going to raise my heart rate and I'm going to vasoconstrict my blood vessels because I'm trying to maintain pressure as much as possible. So I might have tachycardia. I might have a very fast pulse that's very weak and thready. It's a classic sign of shock. My skin might get cold and clammy and cyanotic. Why? Because I just vasoconstricted. Less blood is flowing to my skin. So these baroreceptor and chemoreceptor reflexes are really important. And additionally, to the baroreceptor and chemoreceptor, we're also going to release our epinephrine and norepinephrine and even aldosterone because we're trying to vasoconstrict, raise heart rate, and then ultimately decrease our urine output because we're trying to conserve water, right? We want to hold on to water. We're trying to maintain our blood volume so we can maintain our blood pressure. And so sometimes your body can compensate for this until you get somewhere where they can give you blood and replace the blood loss. And sometimes you can't, and it can be fatal. So when we look at circulatory shock, there's a few types of shock I want you to memorize. And you have 4 in your notes, and you see this little pretty picture, and you have them over here as well. So circulatory shock is characterized by a drop in blood pressure. And when the blood pressure is low, you can't perfuse your organs. So you're going to have multi-organ failure, and they're going to slowly shut down. So what are factors that would do this? Well, in your notes, you have cardiogenic first, so I'll start with that. Well, cardiogenic is there's something wrong with your heart. Maybe you have an arrhythmia. Maybe you're having an MI. Maybe there's a valve problem. So the issue's in the heart and you're not getting the blood out of the heart. So your cardiac output is too low. That's going to lower your blood pressure. Obstructive. When we look at obstructive shock, your heart is fine, but there's something going on with the flow of blood. So, maybe you have that cardiac tamponade that your heart is trying to beat, but it can't beat very well and it can't get the blood out. So this could be a problem with like a clot, right? Like an embolism or a thrombus. Something's obstructing the blood flow. Hypovolemic, I think, is pretty obvious. That's what we started with today. Some sort of hemorrhage. So now we have some sort of bleed happening. Fluid loss, excessive vomiting, diarrhea, usually some sort of trauma would cause this. And then distributive shock is the next one. And when we look at distributive shock, get my picture, we know that the heart is working, but it's characterized by massive vasodilation. So something is making all your blood vessels vasodilate and your pressure's crashing. So things that could do that: sepsis. When you have septic shock can be from a bacterial infection, from toxins from the bacteria. It causes septicemia, which causes this type of shock. Anaphylaxis or anaphylactic shock is due to an immune reaction. So it's a type of shock that happens from a type of allergic reaction. We'll look a little more at that when we study the immune system. And then you can have neurogenic shock. And when we're looking at the neurogenic type, this is usually due to some sort of trauma to the brainstem or problem in the brain that it then triggers this, vasodilation. So distributive is the massive vasodilation, which just drops your blood pressure. Now, when you have shock, just very basically, okay, I just want you to know there's 3 stages and that's it. We're not going into detail. But the first stage is the compensatory or non-progressive. This is when you first go into shock. You might have a weak, thready pulse. You might have the vasoconstriction. And so in this, you can come out of it. So you get treatment. They'll raise your blood pressure depending on what the cause of the shock is, right? They'll have to treat the cause, but you can recover. When you get into progressive, the body switches into positive feedback, which means that you start vasodilating more and more and your blood pressure starts falling lower and lower. If a patient's in this shock, they can recover, but it's quite an emergency because there's a good chance once they start to go into the positive feedback loops that they're going to go into the irreversible shock. And unfortunately, there's really nothing you can do at this point. The organs are going to slowly shut down and you're going to have circulatory collapse and it'll be fatal. Now, I'm ending with this because it's not a joke. My father died. I was with him and he was in the hospital and he was septic and I watched his blood pressure fall. So I only put these things in. I've been through it, but I am trying to make you laugh just a little bit. You can see the 3 phases. We're not memorizing what happens and then, just kind of like trying to make it a little funny. But, there is a stage that unfortunately we can't come back and we lose our patients. So this is the end of our clinical lecture and the last lecture of Unit 1.